Greetings. This is a video about endoscopic multibiopsy and rapid diagnosis with in situ fixation and histopathologic processing. The problem of endoscopic biopsy has only gotten greater and greater. This video describes how multibiopsy transforms endoscopic biopsy by removing the majority of manual labor and exposure to toxic fixatives, sharps, infectious material, and also facilitates histopathologic processing in pathology. Current manual biopsy procedures are untenable in the face of resistant bacteria and the demands for shorter, more efficient procedures, increased productivity, and reduced cost. Shorter procedures with less anesthesia would have great advantages for elderly patients who now often require endoscopy that is prolonged by their needs for biopsy and other activities. The new multiple biopsy is a single-pass instrument that addresses these problems by collecting up to 33 biopsies in a single pass through the endoscope. The technology is like a needle biopsy in that it cuts biopsies of a precise size and depth, avoiding the difficulties of the forceps scraped biopsies that are often inadequate, not deep enough, or too deep, and get lost or destroyed in processing. After diagnostic endoscopy to the distal point, the closed multibiopsy is passed through the endoscope. This requires a 3.2 channel for the current model. Then, during withdrawal of the endoscope, the multibiopsy remains in biopsy position to collect up to 33 biopsies. The biopsies are stacked like coins in the perforated metal tip of the multibiopsy in the order of acquisition, with the first biopsy proximal and the last biopsy distal. After collecting the biopsy series, the last biopsy closes the metal tip so that biopsies are not lost or contaminated on withdrawal, and the staff is protected from the sharp biopsy tip. The endoscopist may use a formatted log that indicates each biopsy's position in the tip that appears on the slide in the same order, and identifies each biopsy as to indication, organ, site, depth, and position in terms of medial, lateral, anterior, posterior. The closed metal tip, after removal from the endoscope, is separated from the shaft and placed in fixative, and then sent to pathology without handling, endoscopist ergonomic stress, staff work, workplace risk, and exposure to toxic fixatives are all minimized. Many vials of carcinogenic formalin are no longer necessary. Each biopsy pass avoided, that is, passing the biopsy instrument, taking the biopsy, removing the biopsy instrument, taking the biopsy into formaldehyde, washing the instrument, and repassing it, requires at least 1 minute. This is saved by multibiopsy. In inflammatory disease surveillance, the previously needed 33 biopsy passes are reduced to a single pass by multiple biopsy. This saves at least 30 minutes of endoscopy time, anesthesia, and facility use per patient. Multibiopsy also allows the performance of frozen section by the pathology department. This provides a diagnosis of cancer in 30 minutes, or if microwave processing is used, in 2 hours. This makes the diagnosis available while the patient is still in the recovery area. Patient risk is reduced and satisfaction improved by shorter procedures with more rapid recovery. Faster diagnosis yields faster therapy. For inpatients, each day saved by more rapid diagnosis is equivalent to the average cost of hospitalization per day in the United States. In the pathology department, the fixed perforated metal tip is processed immediately on arrival. Within the metal tip is a thin plastic cylinder that's also perforated, holding the biopsies in the order of acquisition, oriented and aligned for processing. The plastic cylinder is designed for processing and microtomy with the biopsies in situ. The plastic cylinder is easily removed from the metal tip and processed as a single unit. Slides are produced with numerous serial sections of each biopsy, aligned and oriented on each slide. This avoids the previous delay of grossing many biopsy vial batches from each patient that were previously used to identify the biopsy site. Previously, each biopsy batch of biopsies floating in formaldehyde required filtration to remove the fixative, identification of the number of biopsies and their size against the possibility of biopsy fragmentation and loss during processing, and transfer of this biopsy batch into a processing cassette. To improve information, biopsies could be oriented after processing to paraffin manually. This is no longer necessary with in situ processing that automatically orients and aligns all biopsies. Further, in situ processing prevents biopsy loss, damage, or contamination during processing. If necessary, grossing may be performed from the finished slide using the endoscopist log. In situ plastic chamber biopsy processing proceeds without delay as soon as the biopsies reach the pathology department. This accelerates slide production and diagnosis. Frozen section diagnosis of cancer requires only 30 minutes or by microwave 2 hours, whereas routine paraffin processing requires 6 to 8 hours and is often completed overnight and read on the following day. Multi-biopsy improves pathology service by reducing workplace risk, speeding diagnosis, and reducing cost to increase productivity